So, as you all know, Dr. Harry Hines was a beloved SWOG member and national leader whom we honor each fall with a special lecture in his name. I'm absolutely thrilled to introduce our Harry Hines speaker for 2019, Dr. Olufunmilayo Olopade. She's one of the most notable clinical scientists working in breast cancer today. The winner of a 2005 MacArthur Genius Award and a pioneer of using genetic information to calculate cancer risk, Dr. Olopade is the Walter L. Palmer Distinguished Service Professor of Medicine and Human Genetics at the University of Chicago and the director of the University Center for Clinical Cancer Genetics and Global Health. Her reputation as a researcher is stellar, and her work to reduce cancer disparities is resonant here at SWOG. As you know as well, our NCORE team has focused considerable attention on cancer inequalities, why they occur, whom they affect, how they skew survival benefits, and how barriers to high-quality cancer care might be overcome. Please help me welcome her.
Thank you so much. Well, you've all been sitting for so long. I wonder if you want to just shake your body a little bit, because my device is telling me to stand up.
Perfect.
So when I got the email to come and speak to SWOG in Chicago, I was really delighted, because I'm in that time of the year when I never want to leave Chicago. Summer is beautiful, and then it sort of changes into a nice fall. So thank you very much, Dr. Blank, for asking me to speak. And I really want to just really amuse you about how often we get so wrong with everything we try to say. I have been humbled by the knowledge that we have acquired in genetics. And I've also been humbled by people like Dr. Harry Hines, who was an immigrant like me from Ireland, and then came to this country, really did incredible work from Mayo Clinic, and then ended up in Wichita, Kansas. And some of us live in big city bubbles, and so when I'm in Chicago, in Hyde Park, I'm in one kind of bubble. But then when you go to rural communities and you go to other parts of the country, or you go all over the world and see people with cancer, then you are in a different bubble. So I'm truly, truly honored to be able to have this lectureship and remember people like Dr. Hines, who are great community doctors. Because the challenge we have is that there's a 20% gap in survival between patients who are treated at academic medical centers like mine and those who stay in their communities. Cancer patients need to be in their communities. So I would want to challenge SWOG to prioritize getting your clinical trials to the communities that need them most. Don't bring them to the University of Chicago. All right. Having said that, these are my disclosures, and I may talk about point-of-care testing for cancer. Because what was really clear to me in 1997, and really talking about New England Journal being the source of information, this study was based on 43 patients, and you could see there was a good signal of if you have a germline BRCA1 mutation and you have ovarian cancer and you got platinum-based therapy, you were better than if you did not have a germline BRCA1 mutation. And I had been coming out of the lab looking at the profound effect of in animal models of knocking out BRCA1 and really seeing that there was a really great phenotype in the animal studies. And I had the audacity to say, genetics in clinical cancer care, the future is now. And no one believed me. No one believed me because we all as clinicians, our behaviors are really hard to change. And all I kept hearing was that majority of cancer is sporadic. Why should we spend a lot of money worrying about BRCA1 and BRCA2? Most people don't have cancer. Most people with cancer don't have a mutation. So we went from 1997 through another 2 decades of looking for BRCA2, BRCA3, low penetrance genes, and all sorts of other reasons why we couldn't explain the genetic basis of cancer. So now, in 2019, you can talk about rare high-risk alleles that cause cancer. We can talk about all the things that we know in terms of the genetic basis of cancer. Now we're not talking about one gene, we're talking about just get the whole genome. And I can tell you in 10 years' time, you're going to be talking about the whole genome in your clinical trials. But before we get to whole genome, we're here. And some of the questions that we're already talking about are patients coming to us and looking at breast cancer, single nucleotide polymorphisms. These are just things, variants that we all inherit. Some of you may have heard about pharmacogenomics, variants that predict drug toxicity, variants that predict response on how you should dose your therapy. So what is a clinical trialist supposed to do with all these SNPs and genomics, right? Cancer is complex, and inheritance of cancer is complex, inheritance of toxicity is complex, and yet we have to do clinical trials and get signals that we're now going to say becomes evidence-based medicine. It's going to be challenging. So looking at breast cancer and polygenic risk scores, and by the way, the polygenic risk scores for every complex disease you can ever imagine, including cardiovascular risk factors. In fact, the cardiologists are becoming even more friendly with oncologists because we now have a whole new field of oncocardiology. The reason why this is important, and you should all know about it, is because my colleagues will tell you that you need to recruit large numbers of patients to be able to dissect the heterogeneity in cancer. And so using 190,000 women from UK Biobank, we can actually now look at who's at risk for developing breast cancer. And we can do that better risk prediction, which allows us to go beyond BRCA1 and BRCA2 to population risk stratification. And then for those of you who are lifestyle gurus, you're going to say, even if you have a BRCA1 or a BRCA2 mutation, your DNA isn't your destiny, because my good friend, Dr. Spring, will get you moving, get you motivated. And so what's going to happen? Your patient isn't going to get cancer, and they're going to say, see, you were wrong. You told me I had an increased rate. So this is why when you look at why patients don't trust us or why physicians can't really communicate or connect with their patients, is because we're all not humble enough to say that every experiment we do really proves one hypothesis until another one comes up, right? Because knowledge is constantly evolving, okay? We thought bone marrow transplant would cure breast cancer, and it didn't, and we moved on to something else. Now in breast cancer, we're talking about de-escalation. How do we communicate those moving discoveries into actionable items for our patients in a way that they're going to trust us, and we're going to be humbled by that? So when it comes to genomic testing, what I have learned is that we started really giving guidelines, and we told everyone, well, because we couldn't really interpret the data, we didn't know what it meant. We didn't know penetrance. We couldn't really know who's going to get cancer and who's not going to get it. So keep your genetic testing to cancer patients, because that way you will be able to really interpret the data. And so we told genetic counselors, everyone, start with the cancer patients, because you are thinking about surgical management, risk reduction, and then targeted treatment options. And so for decades, we started with risk assessment for cancer patients. But guess what? We have learned a lot. And we have learned that, in fact, When you do cascade testing and you identify high-risk individual, you have lots of interventions that you can do. And most importantly, we now know that risk assessment may also identify those not at increased risk. One of the most humbling things I learned early on in my career was that many women went to the Mayo Clinic to have bilateral mastectomies because they had a strong family history, had lumpy, bumpy breast, had lobular carcinoma in situ, and had bilateral mastectomy, only to be tested once we had the tools to be found to now actually even carry a familial mutation. So that humility got us thinking about what can we do better? How should we communicate? So we've been thinking a lot about population risk stratification. All of you in here, whether you're a man or a woman, you get the message, go get your mammogram. October, it's Breast Cancer Awareness Month. What is your risk for cancer, right? Do we all have equal risk, or is risk distributed differently in the population? So for those who do population genetics, they'll tell you risk is not distributed equally. So why should we have one message to every woman, go and get your mammogram? There's a category of women who will have extremely high risk. Should we have a different way to talk about risk for them? And then in the US, it was black and white before, but I can tell you, those of you who are here, some of you are neither black nor white, right? In fact, the blackest person I know is Vijay Singh, and if you ask an Indian, are they black, they'll say no, right? And there are many dark Indians who, if you're just talking about black and white, should be black, but they'll tell you black is a social construct in the US, because if you have one drop of black blood because you're of African ancestry, then you are black. So if we collect subtype-specific breast cancer incidence in the US, and for decades, SEER was collecting this in terms of black and white, you will see non-Hispanic whites have the highest rate of breast cancer, right? Because they're the earliest adopter of screening. They're the ones who have access to all of the resources that are available. And so everybody else is undercounted in everything. Because until you get larger populations into your counting, you're going to miss minority populations. So it was interesting when we started doing subtype, and we now had genomic analysis to begin to say, well, there's hormone receptor positive, HER2 negative breast cancer, triple negative breast cancer, HER2 positive breast cancer. And guess what? You can see that even across populations, African Americans have a much higher spike of triple negative breast cancer under the age of 45. So why is it then that we were doing all this research and not really figuring out ancestry? So we asked the question a long time ago, is the burden of lethal breast cancer in the African diaspora due at least in part to differences in the distribution of heritable risk factors for the disease? It was a simple question because I had my medical school training in Nigeria. I came to Cook County Hospital. I live on the south side of Chicago. So I see a lot of black patients or African American patients in my practice. And you know, if you're thinking about population genetics, we all came out of Africa. You all mutated and became white. Right? So if you really want to get to the root of every complex disorder, you should go back to Africa. And I think geneticists will tell you we need to study African genomes to really begin to understand evolutionary pressures that have led to different disease patterns. So that's what I did. I wanted to know what's going on. And it turns out that, in fact, this was the first time that, at least I don't know, maybe if you live in other parts of the world, I used to have Angelina Jolie in this photograph until Tuesday morning when Beyonce's father said, I have BRCA2 mutation and I have breast cancer. These are the things that I have been publishing on since 1996, and I never have seen any celebrity African-American stand up to say, I have a BRCA2 mutation. Why? So what we have done, thanks to the Supreme Court, which made genetic testing actually cheaper, faster, we've gone to look at individuals of African ancestry with breast cancer in Nigeria, Brazil, Cameroon, Uganda, and we've been collaborating with Mary Claire King, and we've talked about the fact that, in fact, whether you look at Hispanics or you look at immigrant groups in this country, the face of breast cancer globally is that of a young woman. And the question is, what proportion of those young immigrants have BRCA1 or BRCA2 mutation? Most people always talk about breast cancer, BRCA1 and BRCA2, and in fact, the Preventive Task Force just modified their guidelines and asked all of us to consider ethnicity when we're thinking about ordering genetic tests. And they said Ashkenazi Jewish ancestry. And I said, well, maybe not so fast to say, think about Ashkenazi Jewish, because if doctors only think about Ashkenazi Jewish, they're going to forget the Mexican woman, they're going to forget the African-American families, and they're only going to be screening for Ashkenazi Jewish. Genetics is one thing that is common in every population. I have Indian families. In fact, at Tata Memorial and in my colleagues who do cancer genetics in India, lots of mutations among triple-negative breast cancer patients. So the reason why this becomes really important is because we now have TCGA. This is the Cancer Genome Atlas, one of the areas that we all go to find druggable targets. And if you look at how TCGA was done, everyone who's trying to find druggable targets using that database will tell you that there's paucity of data on non-European ancestry groups. Breast cancer was the only disease where you actually had more breast cancer cases in TCGA. Why? Because there was a mobilization to get more African-American tumors into TCGA. If you look at other diseases, not there. More Asian liver cancers are in TCGA. There was a concerted effort to do that. So within the US and within all our disease groups, we know that there will be population differences in incidence of different germline mutations. So we compared some of our Nigerian tumors that we're sequencing in my lab, and we've actually done the most important population-based study where we looked at 1,000 cases and 1,000 controls from Nigeria. And guess what? We had 12% of those women had germline BRCA1, 2, or PALB2 as the reason why they developed early onset breast cancer. That's profound compared to TCGA where you have about 4%. So the mutations we found were heterogeneous. Because it's hard to find, that doesn't mean it's not there. It was easier for us to find 3 common mutations among Jewish patients, so we started talking about those 3 common mutations. So I would challenge those of you involved in clinical trials, don't pick the low-hanging fruits. Tackle real problems. So when we looked at whether family history was predictive in Nigeria, it was not. Majority of people who had germline mutations reported no family history, whether they were over 50 or under 50. And that's what we have found every time we have done population-based screening. BRCA1 causes early onset breast cancer, we know that. We know that when those women survive, they get a second primary cancer. We know they also get ovarian cancer. And yet, if you look at population use of genetic testing, even breast cancer survivors are still under-tested because most oncologists forgot to test them or never even considered it. BRCA2, we found BRCA2 because we used male breast cancer. So imagine when my urology colleagues now are getting all excited about prostate cancer and BRCA2. I'd say, I told you that 25 years ago. Right? And the thing is that, and every time I gave lectures in those days, I would say, don't blame the mother alone. A woman cannot have a child just by herself. She needs the sperm from her husband. And so this is why when you now do testing, pancreatic cancer, melanoma, gastric, hematologic malignancies, everyone is finding these DNA repair pathways, this BRCA mutation. And so now that we know that all of our cancer patients may have inherited, some of our cancer patients may have inherited mutations, what are we going to do about it? So I want to come back to the disparity and the age-based screening and racial disparity. So if I go to a predominantly African-American audience, they're going to be passionate and they're going to say, finally, African-American women are getting mammograms, and now you are saying don't get mammograms? That's double speak, right? What age should we get mammogram? Is it 40? Is it 50? Why should we tell everybody start at 40 or 50? So in the US, we sort of average it and say, okay, fine, maybe you can start at 45. What is the evidence for that? When you talk about colorectal cancer, the same thing. Let's average it. Think about prostate cancer. This is a beautiful study from Ghana that the NCI group did. They looked at prevalence of prostate cancer in screened populations. Prevalence of prostate cancer in white men 50 years or older, African Americans 40 to 79, and Ghanaian men 50 to 75 with PSA greater than 4 and an abnormal DRE. You can see that Ghanaians had the highest prevalence of prostate cancer. So the question is, when you put out there that don't get your PSA checked, are you going to hurt African American men? And if you're not going to hurt them, then show us the evidence that you're not going to hurt them, right? So age-based screening and racial disparity. Who should get PSA screening? When should they get PSA screening? So U.S. Preventative Task Force recommended against PSA screening in 2012. Why? Because if you go and get somebody screened and there's no effective treatment, or the quality of treatment in the community is suboptimal, of course they're going to die from the intervention that you just introduced. So this is why if you're going to screen, if you're going to do cancer control, you have to improve the quality of care in communities. Otherwise, you're going to hurt the underserved and underprivileged members of our community. Think about your interventions in terms of the lowest, the most vulnerable of populations. So in my practice, my patients get MRI screening. We are even doing screening in the watchful waiting for prostate cancer. But imagine what happens in topical cancers. So when my patients get BRCA1 or 2 mutation, some of my African-American patients or women in Chicago who are not familiar with having their breast off, in 2004 came to me and said, you know what, I always get a second opinion because I don't want to have my breast removed. So we had this study to actually use MRI to screen BRCA1 mutation carriers. These are breasts that are dense. You're not going to pick them up on a mammogram. These are women who are getting screened every 6 months because we wanted to optimize MRI. And we're picking cancers at 6 millimeter, right? The triple negative, nasty cancer. If we do population risk stratification, we can do better. And we can go beyond just using age as stratification. Adaptive randomization of veliparib, carboplatin, all came about because we were thinking about doing risk stratification. And this was the first study to come out of iSpy showing that adding a PAP inhibitor made a difference. Look at the DNA repair mutations in metastatic prostate cancer. We're now finding 12%, and so everyone now is talking about test all your prostate cancer. Breakthrough status for PARP inhibitors in metastatic prostate cancer. What are you going to do about their family members? So this is a paper from JCO, Evaluation of Streamlined Oncologist-Led BRCA Mutation Testing and Counseling Model for Patients with Ovarian Cancer. Why did they want to do that? Because they wanted to give the patients olaparib or PARP inhibitor. This study would never have happened if not for the brave women who came forward and got into studies that allowed us to find women and families with BRCA1 and BRCA2 mutation. So let me end by saying that the field has evolved now. All of us have indications for finding high-risk women. We have indications for finding high-risk men, and yet we do not have enough genetic counselors. What and where should we be screening to make sure that we can capture individuals who are high risk? This is the challenge I'm throwing to all of us who care about prevention, and I know that the community oncology, CCOP, care about prevention. I know that SWOG cares about prevention because I see all my prevention friends here. But who is high risk, and how do we communicate that risk? This is an example of a polygenic risk score that you will be getting now if you order a genetic test. And it says, here's your breast cancer risk, 31.3%. What does that mean over your lifetime? Women stopped or did not pick up tamoxifen and raloxifene, even though we have all these drugs that could have really been disseminated into our practices that had evidence-based 50% risk reduction for breast cancer. So my challenge to you is let's go from stratification to precision. We're looking now at all these factors, and it's wonderful that we're in the big age of data science, of knowledge to action. We are integrating somatic mutations, germline mutations, targeted therapies. And if you don't act on them and develop clinical trials that really mobilizes and engages all of us, okay? Multidisciplinary collaboration, biospecimen, big data, clinical trials with efficient recruitment, whether you recruit them through the internet or through Twitter, just get a diverse group of patients into clinical trials. And if we do all of this and we don't address universal access to health insurance, we're still going to leave so many people behind who will not be able to take advantage of the amazing clinical trials that your group have been working on over the years. So I'm all about cancer interception now. We know the genes, we know the risk factors, and we don't need to wait until patients have metastatic disease before we intercept. Thank you.